Thank you, everybody, for being here. I want to thank also Ramon. For inviting me here to this conference for honoring Professor Moya. And I beg your pardon for my voice. I get a call 2 weeks ago, and sorry. Well, when I was invited to speak here, I thought, what could I say to specialists in physics and chemistry that could be of both interest for clinicians and also for this audience? And I hesitate, but I talked with Ramon, and he told me, don't worry, you just speak what we are doing, and perhaps it will be of our interest. So I hope so. Well, this is not me, obviously, by the hair, but I have put it here because we as clinicians always are doing ski. We work with two skis, and one ski are things we can control as materials we insert, surgical protocols, etc. But on the other ski are things we do not control, as biology, human behavior, etc. But it doesn't matter what ski go away. If we lose one, we fail. So we have to keep one eye on one ski, but the other eyes in the other one. So to speak, dental disease are considered infectious process. It is agreed that dental loss are exclusively caused by partial and complete dentalism. Some authors argue that loss of teeth is unrelated to the prevalence of dental disease. Sociocultural determinants do that these people do not suffer from dental disease, and these people does. We have to look as well as characteristic things that are culture, access to healthcare systems, and behavioral components, and previous experience to dental treatment, the condition, the response, or the things that do that people lose teeth. Dental implants arguably have now eclipsed most traditional treatment options, since they have been recruited into dentistry's routine treatment repertoire. It was catalyzed by Bronner's seminal research developments. He coined the term Osteointegration for his proposed surgical and loading protocols. Virtually overnight, the notion of a reliable alloplastic analog for a tooth root and its attachment mechanism was matched with the repertoire of prosthodontic technology. A new dentistry was born. I will show you now the process of healing and doing this osteointegration. It will take a few minutes, but I think it will show you, illustrate about the healing process is taken importance of each factor.
Our bones are a marvel of natural design, continuously rejuvenating through a finely balanced equilibrium of bone resorption and new bone formation. A truly miraculous structure is formed which follows the lines of mechanical load, the trabecular bone. Sometimes, however, the unexpected happens. A drill intrudes and destroys the naturally sculpted bone. Blood vessels are torn and a major defect is created, quickly filling with blood. The titanium implant is inserted where the tooth was previously lost. At first, the only force holding the implant in place is mechanical friction. This is called primary implant stability. Osteointegration, or secondary implant stability, requires a highly complex sequence of additional biodynamic processes. This is facilitated by finely tuned communication between the main actors of wound healing, the cells. The blood immediately perfuses the surgical site, providing the cues for subsequent healing. Within seconds or minutes, ions and serum proteins such as albumin, fibrinogen and fibronectin begin adhering to the titanium surface. Next, the bleeding is stopped by blood platelets, also known as thrombocytes. When they are exposed to collagen and other proteins from the traumatized tissue and implant surface, they aggregate and close the ruptured blood vessel. Platelets release various messenger substances for cell-to-cell communication, such as thromboxane, which promotes platelet aggregation, or PDGF, platelet-derived growth factor, which stimulates the cell division of fibroblasts. Fibrin monomers spontaneously cross-link, forming a fibrin network. The blood clot permeates the wound space, forming a provisional matrix. It also adheres to the implant surface. This blood clot has tremendous importance as a provisional matrix for subsequent bone healing processes on the implant surface. During the early stages of healing, immune cells clean the wound of the very fine bone chips, tissue debris, and oral bacteria that remain following the surgical procedure. In a first step, bradykinin from the platelets increases blood vessels' permeability. As a result, the endothelial cells move apart very slightly. On the inside of the vascular walls, endothelial cells promote the attachment of polymorphonuclear leukocytes from the bloodstream. These leukocytes, also known as PMLs, squeeze themselves through the gaps between the endothelial cells. Once they have digested the basal lamina using proteases, they are free to enter the wound. PMLs chemotactically navigate toward the wound along a molecular concentration gradient. These molecules include bacterial proteins, fibrinopeptides, and pro-inflammatory interleukins. Upon arrival, they kill bacteria through the release of reactive oxygen species. PMLs also release highly digestive enzymes such as collagenase and elastase. The wound then proceeds through an uneventful healing process, or a toxic wound environment develops with elevated bacterial counts and toxic byproducts, potentially leading to wound breakdown and implant loss. PMLs can call for auxiliary support, for example through the release of monocyte chemotactic protein, or MCP1. Macrophages respond and are the next actors to arrive on the scene. They too eliminate bacteria by phagocytosis. Tissue debris is taken up and biochemically degraded. Macrophages synthesize pro-inflammatory cytokines and proteases. Macrophages dominate during the late inflammatory phase. Using endiogenic inhibitors for digesting proteinases, the so-called TIMPs, macrophages help stop the round of tissue destruction started by PMLs. This preserves the matrix proteins and proteoglycans in the wound, which in turn protect important growth factors. Messenger substances such as VEGF, PDGF, and FGF stimulate fibroblasts and angiogenesis, which initiate the proliferative phase. Fibroblasts appear on the third or fourth day. They migrate into the wound using amoeboid movements. They synthesize the protective and stabilizing components of the extracellular matrix, such as collagen, elastin, and proteoglycans. The low oxygen concentration in the tissue affects both macrophages and endothelial cells, stimulating them to create the intracellular transcription factor hypoxia-inducible factor, or HIF. Subsequently formed VEGF, in turn, influences periovascular cells. Perivascular cells are mesenchymal stem cells found on blood vessels. They migrate along the VEGF gradient into areas of low partial oxygen pressure. Here they form new blood vessels that finally integrate into the existing vascular network. Angiogenesis restores the oxygen supply and forms the foundation of bone healing. Starting around day 7, activated osteoclasts attach themselves to the fracture edges of the residual bone, resorbing it and creating space for bone healing. However, this will initially reduce the primary stability of the implant. Here, the osteoclasts dissolve the bone using hydrochloric acid and proteases, releasing BMP, TGF-beta, and PDGF from the bone matrix, which in turn initiate the formation of new bone. Perivascular cells not only create new blood vessels, they also migrate toward existing trabeculae and to the implant surface, where they differentiate into new osteoblasts under the influence of BMPs from the dissolved bone. The adsorbed proteins such as fibronectin have a crucial influence on the attachment of bone progenitor cells to the implant surface. The osteoblasts form an organic matrix that is mineralized by incorporating calcium phosphate. Under the optical microscope, bone is visible on the implant surface. Under the electron microscope, though, a thin protein layer is seen between the bone and the titanium surface. Mechanical stability is ensured by interlocking with the surface of the implant. At the end of the first week after surgery, woven bone is formed at the implant surface. This in turn promotes increasing secondary stabilization of the implant, making up for the progressive loss of primary stability. The formation of woven bone concludes the proliferative phase of wound healing. Orderly and coordinated bone remodeling restores the stability of the site. Load adaptation is of pivotal importance in this context. Initially, woven bone will have grown in the valleys of the implant surface and parallel to it. After remodeling, most bone will be structured perpendicularly to the peaks of the implant threads at right angles to the implant surface. The architecture and organization of this bone becomes trabecular. The structure is thought to be directly responsive to forces imposed through the implant to the interfacial tissues. This is made possible by the synergy of osteoblasts and osteoclasts. The osteoclasts, activated by the osteoblast messenger rankle, resorb the woven bone. The osteoblasts then lay down highly organized lamellar bone. The work of both cells is mainly coordinated by the osteocyte and its own messengers, such as sclerostin. Lamellar bone structures are formed. Similar to the arches and vaults in a Gothic cathedral, they absorb the stresses of occlusal load. We are back at an efficient trabecular bone meshwork, perfectly adapted to the new situation. Osteointegration, a highly complex biodynamic process of cell-to-cell communication, is completed.
I think it was important to understand things we'll speak later as bone regeneration. Although implants are frequently described as tooth root analogs, yet the genesis and the specific nature of their interfacial attachment to host bone differ. These differences are subtle but profound in many ways. And their analysis may help highlight the differences in disease initiation and progression. To begin with, the tooth attachment mechanism results from a developmental process driven by genetic influences. Implant, by contrast, are the result of a planned surgical site preparation that is obturated with an alloplastic material and that hopefully results in a controlled healing process. Attachment to epithelium, soft connective tissue, and bone, which are the three tissues that lays beside tooth and implants, is completely different. Epithelium is attached by hemidesmosomes, that is a weak union, and it's quite similar in the case of tooth and in the case of implants. But connective tissue attachment differs completely as occurs with bone. Sharp-edged fibers that compounds the periodontal ligament does not exist in the implant. So they are disposed rounding the implant neck, and that lack of insertion favorites the bacterial colonization. In bone, in the case of implants, there's a direct contact between bone and implant. This is called osteointegration. But in the case of the teeth, there is sharp fibers, this is a ligament, and this permits smooth movements on teeth and also supply blood vessels, which carrier defense cells which can combat bacterial penetration. These bacterial penetrations are, we need to consider that is the colonization and maturization of biofilms depends on favorable ecological environment that lead to shifts in the composition and behavior of endogenous bacteria that may become intolerable for host tissues. In mouth we have bacteria, but the shift to composition and the complex of these bacteria leads to immunogenic reactions that leads to bone resorption. Although osteointegration is achieved with high success rates, we have to deal with bone resorption. It is a whole life process. So if we accumulate here, we live to maturate plaque, we trigger an immunogenic reaction that promotes bone resorption, like we can see here. Implant stability might be compromised. We see suppuration. When we are going to perform the surgical debridement, we see bone loss, and we have to deal with this. Treatment modalities are mechanical cleansing of the bacteria in the surface. Here. We can decontaminate and condition the implant surface, and this is very difficult because the surface is not smooth, it is raw. Reduction of gingival pocket to allow patient to perform correct hygienic practices. And after all, we have to regenerate bone and produce a regeneration of the implant. And here is where materials for bone regeneration appears and are important in treatment implants. When implant bone loss is mild, we can do cleansing treatments. When it is moderate, we do a surgical approach, but as a secondary effect, we have recessions that are not aesthetics, gingival recessions, and we have exposure of the implant neck, so we have complaint of our patients. But when it is severe, we even have to put a new implant or to manage with bone regeneration techniques that are not predictable because we are working with infection, we are working with deficit of blood supply, and it is difficult to regenerate. You have seen in the video that blood supply is critical for bone regeneration. Success parameters for osteointegration. First of all, to use a biocompatibility material. It is crucial. We have focused also on macroscopic design. I'm talking about the millimeter level. We have discussed very much about the shape of the thread of the implant. We have discussed about if it must be parallel or conical. We have talked very much about connection between abutment and implant. I think it is important, but we have to look also to microscopic design. All manufacturers of dental implants have their own treatment of surface, chemical treatment on surface, and they promise they are the best for osseointegration. In fact, although there are many kinds of treatment, many of them get osseointegration, so it is an important topic to look, but it is also important to look to bone quantity and quality. We'll look later. They have talks about roundness of the surface. It is considered that modern round surface as the best to get on osseointegration. Here you can see different implant designs with smooth surface, moderate rough surface, and rough surfaces. We have to look also to the surgical protocol. It is critical to do it with profuse irrigation, to not hit the bone, to follow those steps. And all these conditionants, all these parameters conditions our prosthetical protocol and load. And it is very, very important because our patient demands extraction to place the implant in the same moment, but they also want to leave our office with tooth, although provisional tooth. And we have to look to all these parameters to provide this. We cannot get this with an old implant, with a smooth surface implant. In the video we have seen that when we place an implant, it gets stable, fixed by a notion that is called primary stability. It is fixed by the micro design of the implant. But suddenly, when the osseointegration process begins, there's a loss of this primary integration because of bone resorption. That can be, it is also very important, can be exaggerated by contamination and by immune response. If the implant is contaminated, macrophages exceed in their function, so they resorb and exceed, and osseointegration lose very fast, primary osseointegration. We have to combine this primary with the secondary osseointegration that we get from osseointegration. So the gap, this gap, when primary decrease, but secondary still does not increase, this is the most critical part of the treatment. So we say to the patient, you cannot bite future terms. I think they must go by fasten secondary stability of implants. So the gap is minimized. Because of this, the control of these parameters, we can do to fasten, to do this secondary stability faster, and we could provide our patient with initial dentures, functional dentures, as they leave our office. It is not usual to find a patient with this kind of bone. It's very easy to deal for us with this. We do a bone resorption, we place beautiful teeth, patient leave happy, there's no problem. We have much problems when we found, and usually we found patients that have gone through bone loss and they have also bone resorption in their maxillas. Here you can see a classification of bone resorption, and here bone quality. Here you can see type 1 of bone. It is dense. Although it is dense, it is difficult to work with, because if you are not very sensitive with surgical procedures, protocols, you can overheat the bone, and that's not good for osseointegration, so I don't like this kind of bone. This kind of bone is not type 4. It is like butter, and we work with it not by drilling, but but by compressing bone and converting this kind of bone in a better kind of bone. And best of all, as type 2 and type 3, we work with more confidence in this kind of bone. And bone resorptions really change the lives of our patients. And we need bone to place our implants. When we only have loose teeth, we can place our implants with no problem in the residual bone, and we only place the prostheses, the crowns. But when we have bone, we have lost not only tooth, not only soft tissue, but only the maxilla, we have to deal with a very serious problem. So we have developed techniques to rehabilitate our patients with the available bone. So we place tiled implants, and we place also zygomatic implants looking for the zygomatic anchorage. But size of dentures are obviously higher. Why do we develop these techniques? Because bone regeneration techniques, when we found a defect near the sinus or near the inferior alveolar nerve, bone grafting procedures are not predictable, are very difficult for us. So we intend to get into the residual bone wherever it is. And if we look to studies, when bone quality, cumulative success rate is much lesser, near to 50%, when we are dealing with bone type C, D, or E, while only in good bone we get the success of 95%. Types of bone formation: osteogenesis, which is the primary bone formation through the direct transfer of living bone cells; osteoconduction, growth of bone along surface through the placement of graft that acts as a scaffold; and osteoinduction, transferred by active mediators. Here you can see the phases. We have seen the video. The most delicate phase is this one, resorption phase, in which we lose primary stability, but we still not have secondary stability. And here we can see materials for alveolar ridge reconstructions. Autogenous Bos graft is not immunogenic and transfer freshly obtained bioavailable osteogenic cells, facilitating osteogenesis. It's also associated osteoconductive and osteoinductive capabilities, making it the gold standard of bone grafting materials. The block graft can be contoured to create various sizes and to adapt to patient needs, and we stabilize the graft with screw to the patient because immobilization is critical to allow blood cells to penetrate into bone graft. Allografts and xenografts are osteoconductive, providing a slowly resorbing scaffold for the inbound migration of host pluripotential osteogenic cells from the bone periphery. Both have slightly increased risk of immunogenic reaction and infection, and neither heal as predictable as autogenous bone. These materials take longer to resorb and therefore require longer healing time, 4 months, between 4 and 6 months for allografts and 6 to 8 for xenografts. And a common surgical observation is that xenograft material is still visibly abundant at the time of implant placement, even 12 months after surgery. Alloplasts have the advantage that they do not require, they are wide available, and they do not require a donor site and are artificial bone substitutes that do not also transmit disease as Creutzfeldt-Jakob disease, immunodeficit disease, and so they have become a source of interest in our field. The ideal characteristics of bone alloplast must be, of course, biocompatibility, osteoconductive property. We can tailor them, you can tailor them with osteoinductive proteins. It is very important, the biodegradation rate. If it is very slow, we found that when we are going to perform the second surgery, we have no steel bone, we have the grafting material, and that not allows us to stabilize the implant. But if the biodegradation rate is very fast, it collapses and does not allow bone to penetrate in. We will also point out after the importance of barrier materials. Professor Tomsia before has shown us some radiographs of tibial surgeries in rabbits, and I was wondering which barrier they use, because when we are regenerating bone, we have to think that this bone grafting is inside the whole body. So soft tissue have a rate of reproduction very much high that bone does. So if we do not place a barrier, soft tissue penetrate into bone, and we found that we have get only soft tissue regeneration. It is important to look at the material of that membranes, because if the biodegradation rate of the membrane is faster than the graft, this doesn't work. So we have all sorts of membranes from collagen to polytetrafluoroethyleno membranes that do never resorb, but they implies that we have many times to do a second surgery to retire that membranes. So it is good to tailor membranes that preserve, that work with the biodegradation rate of the bone, so that does not allow soft tissue to penetrate, but finally it is resorbed, so we do not need to perform a second surgery. Mechanical properties, we have talked that it cannot be collapsed, easy to produce, sterilized, handled during surgery. I would also say price, it must be cheaper, and it is good to be radiopack because it allows us to control it after surgery by a radiological procedure. Alloplast, there are different kinds of alloplast. They are very common to use in our field calcium phosphate materials like hydroxyapatita and tricalcium beta phosphate and combinations 60-40, but we often see that when we perform second surgery, they are not resorbed completely. And that's why bioactive glass and glass ceramic like Henge glass and derivatives had been introduced in our field with promising results. This is the original 45S5 bioglass. Suddenly appears a few modifications, you know much more about this. But the fact, what I think when I see so many products, is that none of them works perfectly and requires all our needs. So we are working with Professor Moya and Ramon Torrecilla, and we have developed some papers in this field, working with glass materials for coatings and for bone regeneration. I'm going to show an introduction of our work. Well, it is not me, it is a team. I work with my wife, she's a nurse, and with some colleagues that are doing their doctoral philosophical work with us, with these works. And we work in the minimally invasive surgery center that is placed in Cáceres, and they offer us all the capabilities, and it's really great to work with such professionals. They are specialized in laparoscopic surgery. They have robotic treatment, robotic planning and practices. They also, when you succeed at robotic, you go to work with sheep or with pigs, and after that you go to your hospital and you start to work with human beings. Well, here we are really, we work with veterinary. All procedures are mandatory to be performed under veterinary supervision. Here we have Rafa. He is an anesthetic specialist in animals. He is veterinary. And here we have our director veterinaries, Idoia and Silvia. When animals are taken into surgery theater, they clean their hair, they cut the nails. They really take care of animals. And not only before, also after surgery, they put eyes. They are completely monitored. This is the outline of the study, one of the studies we have performed. We do extractions. After 12 weeks, we realize implant installations and realize clinical examinations. And when healing period has finished about week 20, we perform the abutment connection, and we start a plaque control period. We leave about 4 weeks of plaque control periods to allow soft tissues to adapt, because this soft tissue adaptation often causes a bone resorption. This is called the natural void. Soft tissue requires a void to be handled with the implant. So we experiment a bone resorption that had to be assessed. After that healing preparatory period, we start a passive breakdown period. We interrupt the plaque control, and we lead bacteria to accumulate and to maturate. And we realize microbial samples at the beginning of passive breakdown period and at the end of this passive break period. When we start an active break period, when we induce periimplantitis, bone resorption, by the introduction of silk ligatures that promote plaque accumulation and bone resorption mediated by immunogenic reaction. We take microbial samples at any time, and we also perform radiographic analysis. At the end of the experiments, we leave 2 weeks to stabilize tissues, and they perform euthanasia of animals. As you can see here, veterinary, even taking just a blood vessel, they always are looking and taking care of animals. And all our surgical performs are performed under general anesthesia, so the animal does not suffer at all. Here you can see we have placed 4 implants at a supracrestal level. I will talk about that in a few minutes. Once the healing period has finished, we place the abutment. These are zirconia abutments that will be coated with different materials, and we also put a control one. Here you can see them before surgery, and here you can see them placed. First one is control. This one is G3 glass coating. This one is zinc oxide coating, and this one is nanosilver coating glass. Well, here is the finishing of the plaque control period. You can see that there are a rest of elements here, and we perform our first microbial sample. We are interested in see how microbial develop in contact with our coatings, and here we start our active breakdown period by the insertion of ligatures. They have to be placed in a subgingival position. That is the place where we are interested to promote plaque accumulation. Here you can see the scanning electron micrograph showing the surface of the glassy coatings. Here is G3, here is zinc oxide, and here is nanosilver. And I love this picture because it is taken after passive plaque accumulation. We can see here control. It is completely filled with plaque, and at a microscopic level we can see plenty of bacteria, and this is G3. The coating just reached at this level. So the level that is uncoated, it is completely filled with plaque, but the coating level is nearly not plaque accumulate, you can see. Here you can hardly see any bacteria, but what is very interesting is that when you put this in a plaque and you culture this, they are not viable. So you can harbor some bacteria, but they are not alive. Here we're taking samples, microbial samples, and it is interesting the picture, quality of picture is not good, but here you can see a little gingival inflammation. We think it is related with the coating itself, because it is observed at the beginning of the placement of the coating. But instead, in control and G3, you cannot see nothing of inflammation at all. As the experiment goes on and we are approaching final steps, we can see this situation is completely opposite. We have very good gingiva here, but we have suppuration at control implant. We have induced such an inflammatory and a plaque accumulation process that it has caused suppuration. And here G3 is affected by the suppuration of control implants. But we will see in results that bone resorption has not been affected. Here I show the results for microbial samples. This is for anaerobics, and this is for anaerobics. We have seen that control increased much than other, but for anaerobic it is not significant. Our concern is mainly focused on anaerobic, because they are the one bacteria that cause the bone resorption reaction, not anaerobes. And when we look to the plot of anaerobes, we see that control starts at the same logarithm level, but at the end, here starts the induced periimplantitis, rapidly increase, even higher than 3 logarithms levels, while while nanosilver does not increase even one single logarithm. We also perform radiologic analysis, control radiologic analysis to get parallelized radiographics. Here is the beginning. You can see that bone level is quite similar to all except for nanosilver, which due to the inflammatory reaction that is experienced at the beginning, they also experience initial bone adaptative resorption. But as the experiment developed, we can see that all of them have suffered bone resorption, but in different levels. So the best one is G3, that have suffered a minimum resorption, and the worst increase curve is to control, because they start with no bone resorption at all, but they finish with silver resorption. I know that this level is bad for both, but we have to consider that silver started in a very bad point because of the adaptive response of the healing process. Here you can see the statistical significance, that is not statistical significance at the beginning, so they can be compared, but in the rest of the experiment, statistical significance is shown. And when you compare them to control, you can see that compared to control, it is always statistical significance, but when compared 3 with 2, 2 with 4, or 3 with 4, they are not statistical significance. We perform also other kind of experiments related to bone regeneration. Here you can see Eva and another of our students, our collaborators that are doing the philosophical work. And we create bone defects, shape and tailor-made bone defects to place implants. We create critical size defects, as Professor said. In dentistry, it is considered to be less than 2 millimeters. It is not spontaneously recovered, so we have to create a defect greater than this size. And we fill in with different materials. Some of this is an hydroxyapatite, tricalcium phosphate, a mix in a SPA's machine. And in this, well, here you can see the president of Implant Spanish Implant Society. And this is the block we have get. We perform less diameter drill in the base of the defect to stabilize the implant, and only in the coronal half, we do the higher defect. It is the implant is placed. You can see the critical defect size. It must be preserved higher than the critical size. We put the topper screw to not allow bone healing inside the screw of the implant. We place our research material, and here we are placing a collagen membrane. They are not my favorite ones. There are different kinds of collagen membranes, and depending of the quality, it can be reabsorbed in 1 week or in 2 months. If it is resorbed in 1 week, you allow soft tissues to penetrate in the defect I have created, and when you do histological analysis, you see that it is not good. It is not because of the material, it is because you fail in the barrier. This is very important to develop good barrier materials, and ideally to be resorbable and to avoid and prevent patient for a secondary surgery. Well, this is the commercial one we use. And here you can see another another experiment we perform, that is the placement of rods of zirconia niobio with nanoparticles of niobio to prevent from fractures to spread. So we put it, as it is not a screw-shaped implant, we have to place it as ancient dude with a hammer, okay? Here you can see it placed in the location, but we also, here you can see the procedure, okay? It is important that the drill is a bit smaller than the diameter of the rod, because we need some stability, some contact. If the drill is bigger, the rod will suffer movement, and osseointegration will not succeed. We have also worked with glass rods. This is G3 rods, and here you can see how we place it. Sorry. Now we take the hammer, and although it is a glass, it has mechanical properties enough to resist our work. And it is secure, in good position. Okay. Here I am showing you an analysis, histologic analysis of this rod. This is the rod This is the bone created after bone mass. We can see here vascular cells, and we can also see vascular cells inside the porosity of the rod. The most amazing of this for us is that it has mechanical properties, as you can see. It induces a bone formation in direct contact and inside our material, and it has biocide properties, so we can work with it in infectious places, and we can prevent from reinfection processes. And also, to deal with the resorbable materials allows us to use it as plugs for bone fixations in children. When, as they are growing, you need to reintervene the patient to retrieve the plaque. But if it is resorbed, you avoid this second surgery intervention. So it is very good for children. Here you can see another microscopic analysis of the rod, the direct bone, natural bone, pristine bone, our scaffold, bone form. You can see cells inside. And, well, this is a micrometer where one compound is resorbed and allows blood vessels to penetrate, but another material is stable and provide mechanical properties until the osteointegration is completely achieved. We have get so good results with this material that we have encouraged ourselves to perform other studies with it. So we have intervened pig tibias, and we have performed these defects that are filled with all different kinds of material available in the market. Always things do not go as we would like. And although we perform it carefully, and here you can see how we are preventing contamination of one material with another material, and we do a big effort to get this. Here you can see a natural bone, different kinds of bones available in market. We suture by planes. We use non-resorbable membranes for each defect. We do our best. Here we're suturing subcutaneous tissue and finally skin. We found 1 week later, this infection, big infection in tibias. So we perform a debridement, surgical and chemical debridement. We place drainage to allow cicatrization. And all seems to go correctly, but here is the problem. We use 2 big pits, about 250 kilos of pig, and this is too much for an animal that cannot be avoided to do not walk. You have suffered an intervention, and you have technicians of veterinary doing walk, don't be always sit. Finally, we get this result. We have tibial fractures, and all 4 pigs have to be sacrificed because of tibial fractures. We have searched into the literature, and we have found that Germany have also gone through this same problem with mini pigs of 25 kilograms. So we failed in choosing the animal size. We did it because we needed a tibial enough to perform our size critical defect. But we have learned also from this. To be honest, I also wanted to show you our fail. The same way I show you our chiefs, I wanted to show you our fails. But we have recovered from that, and 2 weeks ago, where I caught my call in surgery, and I do this bound, taking out these molars. It is a big pig also, but in mouth we have no troubles or fractures, and we remove all that teeth, and now we are expecting to 10 December we will perform the implant placement and, the bone defects. We will create the bone defects to fill in with materials you have seen previously in the tibias, and we hope to obtain great results with these G3 materials, and that's the point we are. As Demosthenes said, a prominent Greek statesman and orator of ancient Athens, small opportunities are often the beginning of great enterprises, and so are we dealing with nanoparticles. Thank you very much for your attention.